Good evening, everyone. Thank you so much for joining us tonight on this special occasion for our Woman to Woman health webinar, where you will be hearing from 5 different health experts, part of Mercy and St. Joseph Hospital, on how to live your best healthy life. So we have a really big, robust agenda ready for everyone, and there's different topics that we're going to be talking about. So those include diabetes education, osteoporosis, breast imaging, colon cancer, and preserving your healthy heart. So our first presenter will be Elisa Ferguson, but before that, we want to just go over some rules, and I'll let my colleague Liz Schwind bring you up to speed on those.
Sorry. So honestly, this is going to be about an hour and 15-minute long presentation. So occasionally you're going to want to get up from your computer, do a little stretch. We're going to ask you to do a little stretch during the whole presentation as well. So do it because you're going to need it. Every time someone says the word health, I'd like you to take a sip of water. If you have anything else, that's fine, but I just ask you, I'm going to be taking a sip of water. If you have questions, ask them. At the end of every presentation, someone is going to say questions. Please put them in the chat. Type them in. We will definitely get to all your questions. Also, have fun. Make sure that you enjoy this. This is one of our big first things, and we're very excited about it. No masks are required at this event. If you could tell, we all took them off because we're all sitting somewhere else individually. Also, I just want to let you know this webinar is being recorded, so this will be filtered out other places. I just want to have you aware. Thank you.
So with that being said, I'd like to introduce our first speaker, Elisa Ferguson. She's the Director of Diabetes Education at at St. Joseph Hospital, and she will be talking about healthy eating and movement. Elisa?
Thanks, Alita. So I'm really happy to be here. My background is I'm a dietitian and a diabetes educator. I spend a lot of my time helping adults live with diabetes healthy. So if you know people that have diabetes, I'm here to help. Tonight, I'm going to talk about healthy eating and movement for women specifically. So let's jump in. So what is healthy eating? To me, healthy eating is giving some thought to what and how much we eat and drink, right? And this is an ongoing process because we eat many times a day, every day, right? So this is a journey, not a destination. This is something we're constantly kind of working at and even learning as we go, what works and what doesn't work. I also think it's helpful to think a little bit in advance about what we want to eat, right? So for me, that might be, taking a minute the night before a busy day to figure out how I'm going to eat well the following day, right? So that might be, I don't know, taking meat from the freezer to the refrigerator so that when I get home, it's ready to cook, right? Or it might be, I don't know, throwing together some overnight oats so I have a quick, healthy breakfast on my busy morning. So again, thinking ahead always helps us to make better choices. The opposite is impulsive eating, right? Somebody who doesn't know what they're going to eat for the day. When we make impulsive choices, we tend to, not choose as well or overeat. So I always think about, spreading meals and snacks out and kind of just, again, thinking ahead when possible. Healthy eating doesn't have to be complicated or have super strict rules. For most women I meet, we've all dieted at some point in our lifetime, right? And so when you're on a diet, there's really strict rules. We follow it for a certain period of time, and then what happens? We can't stick to it, right? It's too strict. We can't live like that. So healthy eating is more about making changes that we hope we can stick with. And if you talk to people about food and nutrition, you'll find that there's a lot of conflicting information out there, right? Everybody has opinions about what's healthy or what diet plan is the best. And the rules, they conflict, right? So someone will say, well, eat protein, but meat is bad, right? Or eat vegetables, but carrots have sugar. It's confusing and overwhelming, and then it leaves people feeling stuck. They don't know what to eat. So I'm going to give you some ideas. I hope to help today. Healthy eating is thinking about making good food choices most of the time, right? So that might be a goal of eating healthy, 80% of the time or 90% of the time, which means, maybe 10% of the time we get to eat something because we want to, right? Or it tastes good. Persistence over perfection. So when it comes to food, we're not trying to be perfect. We're trying to work at it, right? We're, again, working on those changes. And then, of course, having support is helpful. For me, healthy eating is a lot about food shopping, right? So how do I know that we're going to get through the week, me and my family eating healthy foods? It means that I have to food shop about once a week, right? If I don't food shop, it means nobody has any idea what we're eating for the week, and we're doing that running and impulsive eating that we all do. And that really compromises the ability to eat healthy when we're eating on the run all the time. So for me, it's food shopping about once a week because I usually need to bring in some fresh food. And then I do other shopping where I stock up on staples and things. And what we buy at the store will dictate hopefully what we eat, right? What we buy or don't buy at the supermarket, right? Will have a big impact on our eating choices. I've been really using online food shopping for a long time now. I feel that it keeps me more organized when it comes to food shopping, right? So I can kind of sit there at home and food shop on my phone, and I can check in my kitchen to see what I'm out of or what I need to use up, and then look up a recipe. And if I forget something, I can add it to my cart the next day. To me, that keeps me organized. But it doesn't matter how you food shop. It's just that you make a commitment to do so and try to choose mostly healthy foods. And I'm going to give you a list in a moment. Lastly, in my family, I'm feeding 3 young children, which means, and one of them is a very picky eater. So that means we tend to eat a lot of the same things, right? We do a Turkey Taco Tuesday, right? And we kind of eat a lot of the same kinds of foods that work for us. But I get bored. So to me, healthy eating is coming up with new ideas, right? Whether it's to eat or to snack or to cook. My favorite way to get inspired for new dinner ideas is skinnytaste.com. I just happen to love her recipes. She always uses a lot of healthy ingredients, like the things I'm about to talk about, vegetables and lean proteins and high fiber grains. She seasons her food well, so it still tastes good. And she includes all the nutrition, which I love. I'm ready for the next slide, Alita. Awesome. All right, so to begin, again, what is healthy eating? What does it look like in a way that's not complicated? Starts with eating lots of high fiber plant foods. So lots of vegetables. We all know this. It doesn't mean that we do it, but right, lots of vegetables. So salads and cooked vegetables. There are no vegetables that are bad vegetables, with very few exceptions. So whatever you like, and make them in ways that taste good. I happen to love roasted vegetables and grilled vegetables, seasoned, so make them so that you'll eat them. Fresh fruits, definitely part of a healthy meal plan. No, don't worry that fresh fruit has some sugar. Fresh fruit is healthy. Legumes, things like beans, split peas, and lentils, very healthy, high fiber plant foods that also have protein and good for you fiber. Next, we have consume lean protein foods. So seafood is fabulous. I always say in my classes, all seafood is good seafood unless it's, deep fried or dripping in butter sauce, right? So all seafood is good. Salmon is special. Shrimp is good. But all seafood is good for you. Skinless poultry is excellent in that it's protein and low in fat. And then lean meats occasionally. That would be things like lean steak, sirloin, eye round, filet mignon, flank steak, London broil, the kind where you look at the meat and it's mostly red, and then maybe that little bit of white on the outside can be trimmed off. Eggs and egg whites, again, healthy foods. I usually mix them. I might do 1 whole egg, add it with a couple whites, mix them together. And then protein shakes can be a good source of protein for us busy women, right? So that could be a ready to drink protein shake, or even better, the kind you make yourself with some protein powder and a healthy milk and some healthy fruit. Next, we have small amounts of healthy fats. So this would be things like olive oil, makes our food taste good. Avocados, yummy on toast or on salad or with as guacamole with vegetables. Nuts and seeds and nut butters, those should be really everyday foods, about a palmful if it's nuts or seeds, or about 1 to 2 spoons if it's nut butter, like peanut butter or almond butter. Hummus is a great healthy food. And then in place of like a stick butter, I like to recommend a vegetable oil spread. I happen to love butter, but I buy what's called Olivio. It comes in a yellow container, kind of similar to something like Promise or Smart Balance. It's a soft spreadable butter that is made mostly from olive oil and canola oil. Next, healthy eating would include some whole grains. So these are usually high fiber ingredients. High fiber grains where the first word is whole. So whole grain rolled oats or steel cut oats, oatmeal, healthy. Usually most things made from whole wheat. So if it's bread, though, it gets complicated. It could be 100% whole wheat. It could be 100% whole grain. It could be multi-grain with multiple whole grains. It could be rye bread. It could be pumpernickel, brown rice, whole wheat pasta, quinoa, Malay. There are lots of whole grains to experiment with. And it doesn't mean that the white ones are bad or terrible. They're just not as healthy and nutritious. Using some low-fat dairy foods is helpful in a meal plan, particularly for women, but really for all people. I like to recommend 1% Fairlife milk. The 1% would mean that it has only a little bit of fat. And the Fairlife brand, they tend to, they put cow's milk through a filtration, so it ends up with less carbohydrates, which matters for my patients with diabetes. They also throw the lactase enzyme, which helps for people that have lactose intolerance. Unsweetened almond milk, also a great choice. And then yogurt. Yogurt can be a really healthy food, you know, as long as you're a label reader, meaning as long as you're glancing at labels for things like added sugars. Some yogurts can sneak in a lot of added sugar, and in general, we are trying to limit added sugars. So I look for the ones that are maybe only lightly sweetened, like Just Too Good, or the healthiest would be like a plain Greek yogurt. And then what you drink, very important, all day long. Lots and lots of water. I happen to be a water drinker and I talk a lot, which makes me thirsty, and then I drink more. But water is the best thing to drink. Sometimes when I'm eating, I find myself wanting something more than water, right? Wanting some flavor. So making flavored waters at home, throwing, you know, lemon, lime, orange, raspberries, you can get fancy, cucumber, melon, make your own flavored water. Or in my life, I buy Hint. Hint is fruit flavored water. And I usually might use that, say, with dinner as almost like something different. Seltzer and flavored seltzer, also great choices. And then coffee and tea are pretty healthy as long as you're not adding a whole lot to them. You know, they're low calorie, they're low carbohydrate, and they have some health benefits because they come from plants. Okay. So that was just really an introduction to healthy eating, but I hope that that was helpful. It just gives us a place to start. Again, when you're going to the food store, what do I buy for me and my family? And I know that falls on us a lot of the time. All right, next, for my last couple of minutes, I want to talk about movement. And again, because I mean, I've worked with women in the field of nutrition for so many years, I meet people that really still think about exercise is almost like a punishment, right? So exercise becomes one more thing we have to do on our to-do list, right? You know, us women, we're caretakers, we're working, we're doing 1,000 things. And so when we get busy, exercise often falls to the bottom of the list. It's the first thing to go. The other thing I see in working with women is, you know, we think that exercise is our way to weight loss, right? And you hear that a lot, right? That if you have to exercise to lose weight, and that's like a partial truth, right? So, I mean, yes, exercise is definitely helpful when you're trying to lose weight and keep it off for sure. But, you know, that association, again, makes it feel like a punishment. So if you exercise and you don't lose weight, is this worth doing? And I'm here to talk about it. It is, right? So movement is like medicine for your body. Okay. And I want you to just change the way you think about it, right? Get rid of the word exercise, right? We're talking about just moving. Every day, moving your body is a gift you give to yourself, right? So it helps you fight stress. It helps you prevent diseases. The number one killers, heart disease, cancer, diabetes. It helps you sleep better, and it helps you feel your best. How do I know this? I try to move every day. And if I don't, I feel it. My body doesn't feel as good. I feel stress more in my shoulders, or I'm, you know, I'm more like short with the kids. So, you know, to me, moving is also just my way to feel my best. And we all deserve to feel that. So I want you to think about walking. Walking is one of the behaviors that works well for most people, not everybody, but it works well for most people. And that what you need to walk is really a good pair of sneakers and a little bit of time, right? And it would be nice if the weather cooperates. You know, right now in the beginning of May, we're going into like a nice month or two of walking weather. So I hope you guys will take advantage of that. But otherwise, it could be walking in a mall in the winter. It could be walking on a treadmill. It could be walking anywhere you can walk. Biking, also a great movement for your body, takes a little bit of the weight off the knees, which is nice. And again, right now we're going into the nicer weather. Bike riding outside is safe and enjoyable. I also got myself a stationary bike so that I have a way to exercise indoors when all else fails, right? When the weather doesn't cooperate. Dancing, fun, put on music, move around, move your body. Find 20 minutes, find 30 minutes every day. This is the amount that's been shown to help with health, right? To get those health benefits that you want. But any amount of movement is good for you. So start with 5 minutes, work it up to 10 minutes. Doesn't have to be all at once. You can do 15 minutes in the morning. You can do 15 minutes after work. You'll get the benefits of doing that 30 minutes all the same, as long as you do it consistently and try not to take more than a day or two off in between when you can't exercise. Thank you. Thank you. So I wanted to just take a minute and see if anyone listening has any further questions. And again, just know that I'm here to help. If you know people living with diabetes, they can call the hospital and ask for me. Thank you.
So Elisa, you have one question here.
Mm-hmm.
And that question is there a limit on the number of eggs per day that you should eat? She's hearing conflicting information.
Yeah, eggs is definitely one that there's a lot of conflicting information. So my answer would probably be 1 whole egg a day is probably fine, meaning both the white and the yolk, right? So the yolk does have some saturated fat and some cholesterol. I'm more concerned about the saturated fat. So if you're eating multiple eggs, right, more than 1 egg, what I would do with the rest of them is use the whites, right? So use 1 whole egg plus as many whites as you want.
Someone also wrote, I've been adding frozen cauliflower to my smoothies, ?
Do it. Cauliflower for everything. Cauliflower is a great, healthy, high fiber, low carb vegetable. So we like to sneak it in whenever we can. I like to make mashed cauliflower. To me, I actually prefer it over the mashed potatoes. It's definitely healthier. I do cauliflower pizza because got to have my pizza. Any way you can have cauliflower, it's usually a good thing.
Great. Any other questions? Okay, right now, after every speaker, we're going to have a trivia just to make sure that we know that everybody's been listening. So I'm going to give you a quick question, and whoever answers correctly first, we're going to send a prize. And we have a lot of prizes to give. Just remember, too, we wanted to let you know that, remember, the first 50 people that registered are getting prizes anyway. So we know that, and let you remember that. Okay, question is, what % during the day should you be making healthy food choices with? What percentage of the day should be made of healthy, good food choices? Okay, somebody wrote 100.
Keisha for 1.
Okay, and Keisha won with the 80, correct?
Yeah, 80 to 90.
80 to 90. Very good, Keisha. So we'll be mailing your gift home with you, with your other thing, okay?
Thank you, Elisa. So now I just want to introduce Laura Hendricks. She's a senior physical therapist at Mercy Hospital, and Laura's going to be talking about osteoporosis, a bone of contention, how exercise can help prevent the disease. Laura, take it over.
Thank you so much, Alita. Good evening, everybody. Thank you so much for being here tonight. We're so happy that you're here. So tonight I'm going to be talking about osteoporosis. And we hear this word all the time, but what does it really mean? So osteoporosis literally means porous bones. So our bones are made up of proteins and minerals, specifically calcium. And when we start to lose those proteins and that calcium, our bones get a little bit less dense, a little bit less strong, a little bit weak, and they're more susceptible to injury and breaking. That's osteoporosis. Our bones get very fragile and they break easily. So how many people have osteoporosis? About 10 million people. Next slide, please. About 10 million Americans have osteoporosis. And of those 10 million, 8 million are women. 1 in 2 women over the age of 50 will break a bone due to osteoporosis. And as we get older than 50, that risk significantly increases. So why are women more susceptible? Well, we have smaller bones, we have thinner bones, less dense bones, and we live a little bit longer. So we have more time to be at more risk. So when we talk about bones, bones are really living, growing tissues. So as we're growing up in our early adolescence up until our 20s, we start to build bone more than we break it down until we hit about 20. And when we're at 20 years old, we've reached our peak bone mass. So the more bone mass we have up until the age 20, the lower risk we have for osteoporosis. So it's super important in those younger adolescent and teen years to really build up those bones through exercise, nutrition, healthy living, because once we hit 20 and we've hit that peak bone mass, now we start to lose more bone than we make. So the higher peak bone mass early on, the better for us, the lower risk for osteoporosis. Next slide, please. So as we get older and we hit midlife, our bone loss speeds up exponentially. Once we hit menopause as women, we have a sharp decline in estrogen and we're at a higher loss for bone density. And 5 to 7 years after menopause, we can lose up to as much as 20% of our bone mass, which is pretty remarkable. That's a lot. So in the next slide here, we have a healthy bone on the left and an osteoporotic bone on the right. So if we look at the healthy bone on the left, we see nice, dense structure, like a nice, strong infrastructure there. We see lots of protein, lots of minerals, nice, healthy bone. And if you can imagine, God forbid, somebody were to fall on a bone like that, the bone is nice and strong and probably won't be injured. If we look at the bone on the right, we see almost like a honeycomb shape. We see less density, we see much more fragile structure. And you can imagine if somebody with a bone that looked like this had a fall, they'd be more likely to have an injury. So how do we prevent osteoporosis? Well, lots of ways. We need to get lots of calcium and vitamin D in our diet. Like Elisa just told us all about healthy eating, it's super important for bone health. We need to have foods that are high in calcium and vitamin D, or supplements as we get older to help us with some of that vitamin D and calcium. And certainly we want to avoid smoking and limit any alcohol intake, which isn't just for healthy bones, that's for healthy lifestyles altogether. And of course, one of the most important ways to get nice, strong, healthy bones and muscles is to exercise. So Wolff's Law tells us that bones will adapt to the amount of stress that we place on them. So nice, healthy bones need to be stressed a little bit. We need to do weight-bearing exercises. So the next thing that we're going to do is we're going to show you an at-home exercise program that we would like for you to do every day, and to do these exercises 2 times a day to help promote healthy bones and nice, strong bones. So there's 5 exercises that we're going to go through right now. We're going to go through squats. We're going to go through kneeling push-ups, side planks, bridging, and clamshells. So I would love for you all to get up off the couch, stand up, and try some of these exercises with us. So before Liz is up. So before we start, I want to say a big thank you to Caitlin Montgomery for being our exercise model and showing us some of these exercises. And very, very important, 2 things that I want to go through as we go through these 5 exercises. I want to make sure that everybody performs these exercises with good body mechanics and does them perfectly so that we don't cause any injury. And the second thing that's super important when we're doing any exercise is we must remember to breathe. It's super important to breathe throughout all of your exercises so we keep our muscles nice and relaxed and we keep our blood pressure nice and even. So before each exercise, I'm just going to go through the body mechanics that we see, and then we'll go ahead and start the videos. So if you look at Caitlin right now, she is standing up nice and tall. Her shoulders are back but relaxed. Her feet are shoulder width apart. She's probably got a nice strong core, and she's got good pelvic stability, and she's in a perfect position to start. So she's going to take a nice deep breath in, and as she exhales, she's going to go ahead and squat down. You can go ahead and start the video. Oh, that's okay. So she's going to go ahead and squat down. And it's important to remember with squats, we want to squat back and put the weight through our heels, almost like we're about to sit down in a chair. Caitlin's going to turn sideways, and you can see that her knees stay right over her feet. They don't go in front of them. And she's sitting back as though she's going to sit in a chair, and then she returns to that nice upright position. So that was perfect. So 2 sets of 10, everybody do them. We're going to move on to the next one. Before we begin, we're going to look at Caitlin's body mechanics again. She's laying on her side with her pelvis stable and her top hip is pointing to the ceiling. She's resting her head on her hand and she's sitting nice and relaxed. So she's going to do the clamshell. Her ankles are going to stay together. She's just going to lift her knee up. She's going to take a nice deep breath. We can go ahead and start the video. And on the exhale, she's going to lift her knee just like that. The ankles stay together and her hips don't really move. She doesn't rock those hips back and forth. And that's a perfect clamshell. 2 sets of 10 of those too. The next one is the side plank. When we look at Caitlin, she's laying on her side and you can see that her shoulder is right over her bent elbow. Her back is nice and straight. Her feet are together and her hip is facing the ceiling. So she's in a nice relaxed position. She's going to take a nice deep breath in. And then on the exhale, she's going to go ahead and lift her lower hip off the table and hold her body nice and still while she's exhaling. And you can start at 5 seconds if you do well with that, 10 seconds. If you want to challenge yourself, you can go ahead and raise your arm up like Caitlin did. 2 sets of 10 of those too. The next one is a kneeling push-up. So Caitlin is about to do a push-up on the mat, but she's using her knees for support. And here you can see our weight-bearing exercise perfectly here. She's weight-bearing through her arms, she's weight-bearing through her legs, and she's going to take a nice deep breath in. And as she pushes down, she exhales and then returns to the starting position. Perfect execution. So 2 sets of 10 of those too. And the last one are bridges. So we start with Caitlin on her back. Her knees are bent, her feet are flat on the mat, and her arms are relaxed at her side. She's going to take a nice deep breath in, and then on the exhale, she's going to bridge up toward the ceiling, and she's going to hold that position for 1 or 2 seconds, and she's going to lift and bridge and slowly lower. And again, remembering to exhale on the lift. 2 sets of 10 of those as well. So those are 5 exercises you can do right in the comfort of your own home. Do them every single day. We've got 206 bones in our body and we need to work them and stress them. So eat healthy, get some vitamin D, get some calcium, and get those bones moving and have fun doing it. Thanks so much. If you have any questions, put them in the chat bar, and thanks for your time.
Laura, there's a question. How does smoking affect bones?
Well, smoking in general is just not a good thing for our lungs. And if we've got lungs that can't work efficiently, that's what I was saying about breathing. Breathing is so important. So if we've got smoke-filled lungs, we're not getting enough oxygen into our body. We're not getting enough oxygen into our bones. They can't really work properly. So smoking is not super healthy for us, and it's not going to allow us to exert ourselves and do our exercises properly.
Okay, next question, Laura. Is it true walking is better than biking for bones because of impact?
So yes, walking is better than biking because you're getting the impact exactly. That's a great way to put it. Biking is great for endurance and for muscle building. But if you want to get stress on those bones, the impact of the walking is great. They're both great for different reasons.
Okay, thank you, Laura.
Thank you.
Okay, our trivia question. 5 to 7 years after menopause, women lose up to what % of bone density? It's a multiple choice, either 10%, 20%, 30%, or 40%. Wow, Brenda Mendez was quick to that. She won that prize.
There's another question too.
Oh, is there one more? I can't see it.
I'll ask you. So there was one more question. I have osteoporosis. How much vitamin D and calcium should I take? And what do you think about acetonel? I don't know. I think I said that wrong. Acetonel.
To be honest, I take a calcium and vitamin. What? Okay.
Can't hear you, Laura.
Can you hear me now? So I would refer the patient to their doctor to ask how much calcium is best for them. Everybody is different. Me personally, I take Citracal with vitamin D every day, but everybody's needs are different depending on, are we in menopause? Are we not in menopause? Where are we in our life cycle? So I would refer patients to their doctor to find out exactly how much calcium is right for them.
Okay, thank you. So up next, we have Dr. Alice Kim. She's the Director of Breast Imaging at Mercy Hospital and St. Joseph Hospital, and she'll be discussing breast imaging, modern technology for diagnosis and treatment. So with that, Dr. Kim.
Hi, how are you? Good to be here today. Today, I'm just going to go over some basic information about breast cancer screening. We're going to start with this slide, and just a basic fact a lot of you may already know is that 1 in 8 women will be diagnosed with breast cancer in their lifetime. So, you know, if we have a room, I think there's about 64 people in this room, 8 of us are going to get breast cancer. Breast cancer is the most common form of cancer in women in the United States. And the American College of Radiology recommends that any woman over the age of 40 start getting annual screening mammography every year. And then some of the benefits of getting annual screening mammography include, you know, having a reduced number of breast cancer deaths, less extensive treatments when the cancers are found, a decreased chance of advanced disease at the time of diagnosis, and the discovery and treatment of high-risk lesions that can predispose the patients to increased risk of breast cancer in the future. Next slide, please. So screening should continue as long as the woman is in good health. Usually they say that if you're going to live at least 10 or more years, you should probably get a screening mammogram. You know, most of the women we have women that come in their 90s and they're still screened. And then you have women that are in their 50s and they're in a nursing home and they don't necessarily need to come in for a screening. So it really depends on the individual situation. Women at high risk of breast cancer, these are women who would also benefit not only from screening mammography and breast ultrasound, but they would benefit from a screening MRI as well. And then if you have any sort of genetic mutations, as the BRCA1 and the BRCA2 genetic mutation, you'd benefit from screening MRI in conjunction with the annual screening mammography and breast ultrasound. If you have any first-degree relatives, your parents, your siblings, or your child that have a genetic mutation, you'd also benefit from the high-risk screening. And if you've gotten radiation therapy to the chest when you were a child, you'd also benefit from the screening MRI. If you have any specific syndromes that predispose you to increased risk of breast cancer, you'd also benefit from screening MRIs in conjunction with a mammogram and breast ultrasound. Next slide. So this is just a general picture of what an ultrasound and a mammogram machine looks like. Both of our facilities, Mercy and St. Joe's, has 3D imaging for a mammogram. It's the updated Hologic machine. So you're getting the latest and greatest technology. Next slide. This is a slide that shows the different types of breast density. So if anybody's gotten a mammogram in the past, you know that if you look back at your report, the first sentence always says what type of density that you have. So on the left side, I don't have the pointer, but the first picture on the left side shows a patient with a fatty tissue. So if this patient develops a cancer, it's going to be pretty obvious to us because cancers show up as a little white spot on the mammogram. So as opposed to all the way on the right side, that patient is extremely dense. So it goes from fatty, scattered, and then heterogeneously dense, and then extremely dense. So if you have extremely dense tissue, it's going to be pretty difficult for us to pick up a tiny, small little cancer. So that's where it's really important that the patients in the third box and the fourth box, if you have heterogeneously dense, and then the last box, if you move over to that one, extremely dense tissue, you'd really benefit from a breast ultrasound in conjunction with the annual screening mammography. Next slide. This is a patient getting a screening MRI. It's always done with the patient lying on their belly, and it's done with the breast coil in place. So it is a little bit uncomfortable in that you have to lie on your belly for about 20 to 30 minutes. But it generates beautiful images. The patients do get IV contrast. It's a form of MRI contrast, gadolinium. And anywhere, if there's a suspicious thing going on the in the breast, it's going to light up like a light bulb. So you can see that it's pretty obvious that there's something going on in the right side. That's the right breast of the patient. Next slide. We also provide at Mercy Hospital something called molecular breast imaging. And this is an example of a patient who got molecular breast imaging. And this is actually an actual case from Mercy Hospital. She came in with a known left breast cancer, which is the third and the fourth images. So if you can, yep, that one and the one, the second one from the left side. So that's the CC projection. And then the last image is the MLO projection. And she already knew about her left breast cancer, but actually when she got this molecular breast imaging done, we saw that there was actually something lighting up in her opposite breast, the right side too. So we ended up biopsying that, and we had to go backwards and repeat the ultrasound to look at that specific location. And she did have another cancer on the other side going on that she didn't know about. Next slide. This is a recent patient who actually came to our hospital, and actually this is that same patient. So when we went back, you can see that there's a little asymmetry on the mammogram and on ultrasound, and that was biopsy proven cancer. That's that same patient. Next slide. This is a patient who came in for a screening mammogram, and she got really lucky because, and I'm not sure if it projects well, but she had a new finding. The 2021 images, the CC and MLOs are the first and the third images from the left. And then she had a comparison from 2015, and you can see that there's been an interval change. So we ended up doing some extra mammogram pictures. Next slide, please. So this is something called the spot compression views, where we try to put extra pressure on the breast so that we can spread out any overlapping tissue. But you can see that there's definitely a little density that persists even when we put extra pressure right on that specific area. And so as a result, this patient ended up getting an ultrasound to see, the ultrasound's done to see if there's an underlying cyst or a mass. And there was a little mass there, and that was biopsied. Next picture. And that was cancer. And what we do is we do the biopsy, we put a little marker clip in, and I don't know if you can see, but there's a little Q-shaped marker clip right in the area of that asymmetry that I had circled before. So everything, we close the loop, and we know that we biopsied the correct finding on the mammogram. And this patient actually, a lot of patients do end up getting further evaluation with an MRI, but unfortunately she had a heart issue and she couldn't go into the MRI machine. So she actually ended up getting a molecular breast imaging study. And you can see that there's faint radiotracer uptake right in the area of her cancer. And there's a little bit of post-biopsy changes, but nothing else was shown. So she was all set, and she actually got operated on within a week after her diagnosis. So we have a really good turnaround time with our breast surgeons. Next slide. So that's pretty much, I gave you a very quick whirlwind tour of breast imaging. I'll take any questions if anybody has anything. And also, actually, and I forgot to mention Pink Aid. If anybody does not have insurance, Mercy Hospital provides a service called Pink Aid. We've been partnering with them for the last 5 years, and it's been a true honor and amazing opportunity to really help those people in need that don't have health insurance. Feel free to come in. We take walk-ins. We have free, the first Saturday of the month is a free screening Saturday. So feel free to sign up for that. I believe we can give you the phone number for that in a little bit. So there's a lot of opportunities. Please don't wait to develop symptoms. Come in when you're asymptomatic. It's best to pick it up when it's nice and small so that it's easier for the surgeons to treat.
Okay. Dr. Kim, I have a couple of questions for you.
Sure.
Breast cancer screening after cancer diagnosis and mastectomy is breast MRI is every 2 years. What do you think of ultrasound yearly?
Yeah, that's really dependent on the breast surgeon. A lot of surgeons do send the patients back yearly for an ultrasound. And I believe that the surgeons also do pretty good clinical breast exams on the patients who've had mastectomies. So if they feel that they feel a new lump or there's been a change, then they'll send them in sooner.
Okay, from Liz, is this traditional machine still so painful with the compression? She always feels like her shoulder is getting in there.
You mean the tomogram, the 3D tomo mammogram? As you know, it's actually it actually depends on the mammography technologist. It's not the machine itself. It's the way that they're pretty gentle at Mercy. I have to say, I've gotten my own mammogram there. But they do have to put some degree of compression on it. Otherwise, like I said before, sometimes if we don't put enough, then it'll look like there's a finding when there isn't. So we have to spread it out further with those extra little, the small spot compression views that I showed you before. So they're just doing their job of trying to press everything out, because sometimes it could look the same as a cancer.
Okay. The next question, does a regular PCP provide these same services during an annual well women's exam?
Yes. So like, for example, my primary care doctor does do a breast exam, but some primary care doctors don't feel comfortable with, they don't feel comfortable doing a breast exam. And I know with the COVID situation right now, some people, only do like the limited, check your heart, lungs, that kind of stuff. I believe gynecologists have been really good about doing clinical breast exams, but if you really want a very good breast exam, I would go to see a breast surgeon. They are the experts in doing breast exams.
Okay. Is there a big difference between 3D mammo and regular mammo?
Absolutely, yes. So you can think of it as I usually describe to my patients that 2D mammo, which is what we were doing back in the early 2000s, the digital 2D mammo was like slicing an orange just in half. So you have two pieces, you have two halves of an orange. The 3D mammo, you get 9 slices of it. So you slice an orange in 9 different slices. So you're getting thinner cuts through the breast. So we're not just slicing it straight down the middle, but we're getting 9 different slices of it. So yes, we're getting a better look at what's going on in the breast.
And these 3D mammos are both at St. Joe's and at Mercy?
Yes.
You have that both? Okay.
Yes.
Can your breast tissue become less dense?
Yes, as you become older, some women do get less dense, but that's not always the case. We do have 80, 90-year-olds who come in and they have very dense breast tissue as if they look like they're 40. But yes, as you get older, if you gain weight, you definitely have more fatty tissue. If you lose weight, you're going to be more dense. So those are the different things that can affect your breast density.
Great questions, everybody.
Absolutely. Thank you.
Dr.
You're welcome.
Okay, trivia. Is breast cancer the most common form of cancer in the US? True or false?
No.
Yes or no, true or false? Dorothy Lee, we're true. Yes, it is.
Thank you, Dr. Kim, and especially thank you for sharing the information about Pinkade. I think now more than ever with COVID and some people who have lost their health insurance, having access to getting their breast exam and screenings is more important than ever. And so Pinkade providing that service, we're really thankful for that. And also thankful for, I know this year they changed the age restrictions from 45 to 40, so even more women are able to get help. So thanks again. So our next speaker is Dr. Lynn O'Connor. She is the Chief of Colon and Rectal Surgery at Mercy Hospital and St. Joseph Hospital. And Dr. O'Connor will be talking to you about colon cancer 101 and colon cancer awareness.
Yes, thank you very much. Thank you for having me tonight. We've had some really good talks, so this is a lot of important information. So I want to zoom right in on colorectal cancer. Cancer itself is the second leading cause of death in the United States. It's surpassed only by heart disease. But when you look specifically at colorectal cancer, that's the second most common cause of cancer death in the United States. Men and women are somewhat affected equally. And last year, the American Cancer Society predicted we have about 148,000 new cases of colorectal cancer in the United States with 53,000 deaths. 12% of those new cases and 7% of those deaths were predicted to be in patients younger than 50 years of age. Next slide. So we are seeing a significant increase in the incidence of colon cancer in the young patients. Folks between 20 to 39 years of age had a 1 to 2% increase over the last couple of decades, and those who are 40 to 54 had a 0.5 to 1% increase. Now, when you look at rectal cancer, that's even double. So for the 20 to 29 year group and the 30 to 39 year group, there was a 3% increase per year. And the 40 to 54 year group had a 2% increase per year. Next slide. So, when you look at colorectal cancer, it's still a disease of older patients, and they more often develop colorectal cancer than younger patients. But because of the fact that we are seeing younger and younger patients, the cohort of disease is shifting younger. or more than 20 years younger. So the median age was 72. It is now 66. Next slide. So what can we do to prevent this? There are a lot of risk factors that we talked about. And you've heard it with osteoporosis, you've heard it with healthy eating, with diabetes. It really is how we modify our risk factors. And these are preventable risk factors. Diets high in saturated fat, such as Burger King, McDonald's, the high fatty foods, the greasy foods, the fried foods. Those are the ones that studies have shown may be a causative factor for colon cancer. Physical inactivity. We're more couch potatoes at this point right now. We can get our phones and we can order Uber Eats. We don't get out. We're not walking. We're not. Some of us are still not working, so we're not getting that physical activity that we need. Smoking, hands down, is one of the most preventable and modifiable risk factors for all kinds of cancer. And excessive alcohol, especially with the pandemic, the amount of people who are drinking has significantly increased. Online sales have gone up 500%. So excessive alcohol is a significantly preventable, modifiable risk factor that we have for colon cancer. And also patient misconceptions. A lot of patients are scared of the prep. They're scared of anesthesia. They're scared of having the procedure. So that stops them from getting the screening colonoscopies that they need. Next slide. So when you look at colon cancer in women, the mean age of diagnosis in women is a lot later than men. It's 71, and men it's 67. Same thing for rectal cancer. Colon cancer is more likely to affect older women who are no longer menstruating. Don't forget, though, the number of people under 50 who are diagnosed with colorectal cancer is still rising. Next slide. So when you're thinking about colorectal cancer, you're going to think about the signs and the symptoms. And when you're talking about advanced signs, we're looking at partial obstruction. We're looking at change in bowel habits. We're looking at bleeding. And when you think about those change in bowel habits, maybe you're not moving your bowels as much as you normally do. You usually go every day or every other day. Now it's every 2 days. Now it's every 3 days. Instead of it being a form stool, it's more small, it's skinnier. Now you're starting to see blood on the tissue and in the toilet paper. You may have some abdominal discomfort and pain. And then you may have some unexplained weight loss and fatigue. Most colorectal cancers are asymptomatic until they become advanced. And when you get advanced signs and symptoms, that's when you're going to see the ones I just talked about. Next slide. So when you're dealing with colorectal cancer in women, there are some symptoms of colorectal cancer that may be mistaken for normal symptoms of menstruation or gynecological issues, such as the change in bowel habits I talked about, diarrhea and constipation. A lot of my patients are concerned when they come in, but those are normal signs and symptoms sometimes that surround your menstrual cycle. Abdominal cramping can also be mistaken for menstrual cramping. And those feelings of tiredness and just fatigue can be dismissed as being due to premenstrual syndrome. So if you have signs and symptoms, don't get them mixed up. It's always important to make sure that you see your doctor. Next slide. So the purpose of screening basically is to identify these precancerous polyps before they turn into a cancer. You want to detect these cancers at an early stage because early detection equals prevention. If you get a polyp before it becomes a cancer, we prevented a cancer. If you get a cancer at an earlier stage, then you've increased your ability for a cure. Next slide. And that's what I want to go over with staging, because stage 0, that's when the cancer has really just confined to the lining of the wall of the colon. The problem is only 33% of cancers are diagnosed at this stage. But the earlier stage you have, the 5-year survival is 95%. When you get to the further stages on the right, such as stage 3, that's the cancer that's gone through the wall of the colon and you're having surrounding lymph nodes. These are the people who are going to need chemotherapy and other interventions. Stage 4 disease, unfortunately, is tumor that spread beyond the wall of the colon into the lymph nodes and into surrounding structures such as the liver or the brain. Next slide. So you're asking yourself, who should be screened and when? 75% of new cases of colorectal cancer are found in average risk patients. Who are average risk? That's you and me with no symptoms whatsoever and no family history. That's the majority of people who we find colorectal cancer in, which is why screening is so important. And the remaining cases occur in patients who have higher than average risk, which we'll get into later. Next slide. So your risk groups are stratified into different groups. Minimal risk is someone who has no symptoms and they're simply less than 45 years of age. Low risk is age 45 and no GI symptoms. And those GI symptoms we talked about, bleeding, abdominal pain, change in bowel habits. And the American Cancer Society has lowered the screening age for colorectal cancer to 45. So 45 is the new 50, and that's low risk. Now, when you're talking about moderate risk, these are people who may have a previous polyp, people who have had cancer, if they have a family history. And family history is mostly talking about your first degree relatives, such as mom, dad, brother, or sister. Now, it's important to know if your uncles and your cousins and your grandparents had it, but we're really looking at the first degree relatives when you're talking about family history. If you're going to look at a genetic predisposition, that's when different generations come in. And those are people who are high risk, and we're not going to talk about that in this segment tonight. And also moderate is people who have GI symptoms. So even if you're not 45 and you simply have change in bowel habits, you have rectal bleeding, you have weight loss, you have a change in your appetite, you don't feel like eating, those are the signs and symptoms, hands down, that makes you want to come to the attention of your doctor and possibly get screened. Next slide. So I want to briefly go into some of the screening tests that we have for colorectal cancer. My patients always ask me, Dr. O'Connor, what is the best test? And I always tell them the best test is the one that's done. So we're going to look into fecal occult blood testing, flexible sigmoidoscopies, FIT testing, Cologuard, and colonoscopy. Next slide. Well, we've all seen this little card. It's the fecal occult blood test card, and that's the one we get at our doctor. They give us 3 cards. On the left-hand side, you'll see that the card has a little bit of just a white background to it. This is a card that's negative. If you look on the right-hand side, you'll see that there's a blue reagent to it. This is a card that's positive. You're going to take a little piece of stool, you put it on the back of the card, and then a dropper is placed on, and it turns it either dark blue, which is positive, or there's no color change, which is negative. Next slide. Cancers bleed more than normal tissue, which is why they use the fecal occult blood test. But the problem is our bleeding is intermittent and uneven. So you may take a little piece of that stool that doesn't have the blood in it. However, bleeding increases with the size of the polyp and the stage of the cancer. Greater than 90% of cancers will be detected with repeat testing over several years. But this is something that you want to know sooner rather than later. Next slide. Fecal occult blood test, the disadvantages, it's not specific for cancer. There are certain medications and there are certain foods that will give you a false positive result. And if you don't have the proper amount of stool that may have some of the bleeding in there, you'll get a false negative result. And it's not specific for blood. In this type of test, yearly testing is recommended, and patients really don't want to change their diet. They may not be able to eat certain foods. Red meats may turn this a false positive. Beets can turn it a false positive, and certain medications. So there's dietary restrictions that most patients really don't want to do. Next slide. The fecal immunochemical test. Now this one is more specific because it tests for hidden blood in the stool, and it only detects blood from the lower intestines. So the fecal occult blood test, the one we just saw, if you have an upper GI bleed, it's still going to be positive. But this one is specific just for lower intestinal bleed. And this one is better because you don't have to change your medicines, you don't have to stop them, and you don't have to change your diet. It's more accurate. It's about 70% positive, and you have 70% more accurate, and you have fewer false positive results because it detects specifically for lower intestinal bleeding, and you don't have to change your diet or your medications. This one is done every 3 years, so patients like that a little bit better. Next slide. Cologuard, we've all heard get, go, gone. This one is a stool sample as well. And most patients like this because you don't have to actually physically touch the stool. It comes in a kit, and it detects stool DNA and hemoglobin. It is 92% accurate for cancer. But the problem is it's only 42% accurate for colon polyps. And that's when we want to get the detection, when it's a polyp before it becomes a cancer. As you get older, the false positive rate increases, but this is still better than the FIT test, and it's also better than the fecal occult blood test. The drawback is, though, it's only 42% accurate for colon polyps. Next slide. A flexible sigmoidoscopy is really good. It only requires an enema 1 to 2 hours before the exam. You can do it quickly in the doctor's office, and it has advantages over the other tests that it allows for direct visualization of the bowel. You can also biopsy lesions, and it's very sensitive and specific for polyps because you can see them and you can biopsy them. The disadvantage is it's only suited to the left side of the colon. And if you're African American, for some reason, polyps are more right-sided and cancers are more right-sided. Next slide. This is a picture of what a flexible sigmoidoscope looks like. Next slide. And you can see that this is the path of this flexible sigmoidoscope. It only goes up to the left side of the colon. So you're only going to be able to look at a lower half of the colon with a flexible sigmoidoscope. Next slide. Now, when you're looking at a colonoscopy, this is the only technique that looks at the entire colon, and it's used for detection and treatment. The fecal occult blood test and the fecal immunochemical test, that allows you to detect only polyps and cancers that bleed, but you can't treat them. You can detect them. So if you do have that test and it's positive, you will need to go on to have a colonoscopy. A sigmoidoscopy only allows for detection in the lower half of the colon, and Cologuard doesn't allow you to biopsy or do a polypectomy. Next slide. So there are a lot of myths about colonoscopy, but let me dispel some of them for you. A mechanical bowel preparation is required, and because we really need to see the colon. Patients are usually sedated. It's the best nap ever. And you can detect both carcinomas and polyps. Detection and removal of polyps, it lowers the incidence of colorectal cancer because we get these polyps before they turn into a cancer. And it detects early stage cancers, which can lower the mortality rate. The rate of bleeding and perforation with colonoscopy is extremely low. Next slide. This is what a colonoscope looks like, and you can see that it's a lot longer than the flexible sigmoidoscope because we have to go around the entire colon. Next slide. And this is a picture of what the average colon looks like. Doesn't matter if you're a man or woman, the average colon is anywhere from 5 to 6 feet long. So I will look at everything, and that's how long the scope needs to be. Next slide. So the polyp that's on the left, that's more of a small, benign looking polyp, and that's what I would normally see during a colonoscopy, and I remove them regardless of whether they look benign or malignant. Now the polyp on the right, you can see it's a little larger, it's a little more fleshy, it's a little more red, and it's a little more grainy. That's one that I'm concerned about, and that's something that we would be able to detect and remove during a colonoscopy. Next slide. This is a picture of one of the cancer, and you can see that the lumen of the colon is now filled with a lot of tumor. And this is why you will have your change in bowel habits, because you normally have a larger diameter for the stool to go through. It is now much smaller. So your stools are going to be smaller. They're going to be thin. And then you can see that the cancer is bleeding. So that's why when the stool comes through, you're going to get some blood incorporated with that, and you'll have blood in your stool. So this is where the fecal occult blood test and the fecal immunochemical test can help, as well as the Cologuard. And this is also where you might have that abdominal pain because this is starting to stretch the bowel. So you have change in bowel habits. You're not going to be as hungry as you are because you're getting backed up. And the reason you're getting backed up is you can't push the stool through because there's not a lot of room. So this is advanced, and that's when you have all those advanced signs and symptoms. Next slide. This is a cold pathology study this is an example of the specimen that I would take out during a colonoscopy. You can see there's a polyp on the left, there's a polyp on the right, and the cancer is in the middle. Next slide. So we want to prevent this. And we talked about this throughout, that's the theme throughout this entire program, is healthy habits, getting out, exercising, simply just 30 minutes of moderate activity a day, walking. And again, it does not have to be all at once. It can be 10 minutes in the morning, 10 minutes at night, 10 minutes on your lunch hour. Getting enough sleep is key. Healthy eating, fruits, vegetables, and fiber have been shown to help stave off and prevent colon cancer, as well as limiting alcohol. So you don't want excess of alcohol. Women, 1 drink a day, men 2. And smoking of any kind, whether it's cigarettes, vaping, cannabis, all of that is an absolute no. Next slide. So the recommendations are you want to begin colorectal cancer screening at 45, not 50. Colonoscopy is the preferred method for screening, especially for folks who may have right-sided cancers. You want to control your risk factors. That's the eating, the exercise, the working out, the smoking. And you want to be your own advocate. Push for screening. There are so many young patients out there who may have some of these signs and symptoms. Just because you're not 45 doesn't mean that you don't need to have a colonoscopy. If you have some signs, you have some symptoms, if you're concerned, see your doctor. You may have to push for your own advocacy for screening. Next slide. And lastly, I just want to touch on hormone replacement therapy. Studies have shown that hormone replacement therapy after menopause can lower the risk of colorectal cancer, but these findings are still under investigation. The decision to begin should not be based just on you're trying to prevent colorectal cancer, because estrogen and progesterone after menopause can increase the risk of a variety of other diseases, as well as lung and breast cancer. So that's something that you're going to speak with your gynecologist about. Last slide. Don't be afraid to ask, okay? Colorectal cancer can be frightening. The screening can be scary. You don't know what's going on, but not knowing whether symptoms are from colon cancer, menstruation, gynecological issues can be difficult. So when in doubt, seek your doctor and ask. And just because you have symptoms, it doesn't mean you have cancer. When in doubt, look about and see your doctor. Thank you.
Great. Thank you, Dr. O'Connor. We have a couple of questions. Does HPV cause colon cancer?
HPV does not cause colon cancer. HPV is more implicated in anal cancer. And we found a lot of that studies during when you were anal receptive intercourse, and there were a lot of issues with that in the earlier 80s with the HIV and then having sex with men. But it's usually the anal cancer that you have the HPV implicated in. So it's not a colon cancer, it's anal cancer.
Okay. How often does one need to get a colonoscopy after benign polyp removal?
It depends. If you have multiple, if you have 3 or more benign colon polyps, and if you have, and the size of those benign colon polyps, and we're saying benign meaning that they're adenomatous, they're not cancerous, but they're precancerous, then I recommend my patients to come back in 3 years. But if you've had a family history of colon cancer, we find polyps on you regularly, then you may even come back as soon as 1 year. But as far as if patients have a negative colonoscopy every 5 years, I recommend they come back. The American Cancer Society recommends 10, but we're finding that that may be too much of a long interval, so that's being investigated. But again, if you do have multiple adenomatous polyps, you may need to be screened sooner rather than waiting the recommended 10 years.
Typically, would a patient need to request like any kind of test or an exam from their physician to schedule an appointment with the specialist if they go to a regular doctor?
If you go to your regular doctor, they should be sending you at the time of 45 years of age for screening. If you're going and you have some symptoms, then you should request to have a schedule and an appointment with the specialist right then and there. It depends on your insurance whether or not you actually need a referral. Some insurances will let you see the specialist without a referral, but just in doubt, when in doubt, just call your insurance company and you will have to decide whether you'll need a referral or you can go directly to the specialist.
Great. Thank you, Dr. O'Connor. Okay, her question. Colon cancer is more likely to affect women who are menstruating, true or false?
We got some answers.
Yep, we got some answers. Ophi? She got it. Okay.
There's one more question.
Okay. Let me see. One more question, Dr. O'Connor.
Okay.
No, I don't see it. Do you see it?
I see it. Does the history of breast cancer under the age of 40 require an early colonoscopy screening?
Yes, I would recommend that if there's a history of breast cancer, period, that a patient undergo colonoscopy screening. We have a very close relationship with the breast surgeons and at Mercy and St. Joe's and the other hospitals that I go to, and they typically send the patients for colonoscopies.
Okay, great. Thank you, Dr. O'Connor. Next, last but definitely not least, is Dr. Marilyn Changat. She's a cardiologist at Mercy Hospital and St. Joseph Hospital. And Dr. Changat will be talking to us today about how we can preserve our healthy heart. And remember, health, drink some water. Thank you, Dr. Changat.
Well, thank you guys for having me. All right, good evening, everybody. So I decided to kind of go through some of my favorite things, and I do this on a daily basis. So prevention is something that I absolutely love, something I am very passionate about. So I thought we'd start with my favorite top 10. Okay, next slide. All right, knowledge is prevention. This is number one, know your numbers. So there's a couple of things I think every woman genuinely should know. You should know your blood pressure, the top number and the bottom number. You should know your cholesterol, the good stuff and the bad stuff. So the good cholesterol being your HDL, the bad cholesterol being your LDL. You should know your BMI, which is your body mass index. There's a simple calculator. You take your height, you take your weight. You go on Google, type in BMI calculator. There's plenty of different places to get that BMI number from. Your waist circumference. We've all got a tape measure. You don't have one at home. I'm sure they're easy enough to find. Get one, put it around the waist. It's going to be above, it's going to be right around where the navel is. You want to know what that number is. We'll get to why that's important. Most of us have been to a physician, or if you're at a point where you're doing your regular physicals, there's a couple of things you should pick out in addition to your cholesterol on your blood work. Know what your blood glucose is or your A1C. It's important to know that number. And the other thing I think a lot of us should be aware of is what's your resting heart rate? How many people here have a Fitbit or have an Apple Watch or something that they know what their heart rate is? I've got mine on now. And the amount of people I have that come into my office that ask, is this normal? Or I'm seeing this with my heart rate. It's important to know those numbers for yourself, to always have a good frame of reference. When you talk to your doctors, you want to make something better. You want to know, is this normal? It's good to know what your numbers are, not what normal should be for everybody. Know where yours are in relationship to where they fit. Next slide. Number two, and this is going to follow along with a lot of the things that we've discussed. And what I think is nice is you see that it's not just keeping your heart healthy. It's not about keeping your colon healthy. It's not about just having a proper weight. It's how eating healthy and putting the right things in your body are incredibly important to keep you in the best shape possible. So you want to remember, and this has already been discussed, so I apologize for the repetition, but you want to remember to have a few servings every day of colorful fruits and vegetables. You want to put good fiber into your diet. You want to increase your fish consumption over red meat. And you're going to try to avoid your foods that have high saturated fats, things that are sodium loaded, things that are sugar loaded, things that are highly processed foods. You want to drink plenty of water. You want to eliminate how much caffeine you take in. An important point, on a personal note, I'm a mom. I have two young kids. I have a 2.5 and a 4-year-old. And it's so important for what I see that goes on in our household. It also translates to your children and to the other people in your family who are around you. If you don't set that good example, particularly from what I've seen with children, they're not going to do it just because you told them. So set that example. It's very important to help establish those habits through your whole household. Next slide. Exercise, we've talked about this already, but you want to try to exercise at least 30 minutes a day. It's necessary to lower your risk of heart attack, for stroke, to help maintain a healthy blood pressure, to keep your cholesterol in check, to prevent diabetes, to prevent obesity. Almost 64% of women in the US are overweight or they're obese. And just 30 minutes a day of walking can keep your heart healthy. If you can't do the 30 minutes a day, if you can do 75 minutes twice a week, in addition to doing some strength-based exercises, is a great way to try to keep heart disease at bay. I have people who say, I can't find the time, things are busy. If you can't do the 30 minutes at once, break it up. Take a 10-minute walk, take a 10-minute walk later. Try to find that time. If we can find the time to sit down and watch TV, find that time to scroll through Facebook, do things on your social media, you can find those 30 minutes in a given day to move yourself. It's important. Next slide. Know the heart attack warning signs and don't wait to call 911. Each year, 1.1 million Americans have a heart attack, including out of that 435,000 women. And very sadly, heart attacks claim the lives of about 267,000 women a year. That's a lot. Most female heart attacks do occur in the postmenopausal period after the age of 50, but younger women can also have a heart attack. Next slide. The most common symptom of a heart attack, I think in general, everyone is very familiar with your textbook scenario of I have pain in my chest, maybe there's pain down my arm, but that's not how everybody presents. Now, a lot more and more patients I see are aware that there are other symptoms or that women may present atypically. But it is important to remember the most common symptom is chest pain. So don't forget that part. So, I don't want anybody to turn around and say, well, Dr. Changad said, it's atypical and I won't present with chest pain. It still is the most common, but there are a lot of other symptoms that can come across. So for women in particular, nausea and vomiting is very common for what I've seen with angina. It's very common. People have oftentimes taken extra time or maybe passed it off and said, well, it's probably just indigestion. I ate something funny. They start taking Tums. I have told every patient, if any of my patients are here, I've said this to you. You know your indigestion. If you are feeling something that is not your indigestion, it needs to get checked out. Don't pass that symptom off. Jaw pain, neck pain, upper back pain. Again, I mentioned chest pain, most common. And sometimes it's not pain. It can be pressure. It can feel like it's tight. It doesn't have to necessarily be that stabbing pain that you may think that that's what angina or chest pain should feel like. Feeling short of breath, an extremely common symptom I've seen in women. Lightheadedness, fainting, and feeling very, very exhausted in a way that doesn't make sense to you. These are all things that you need to mention to your doctor to say something doesn't feel right. And one of the things I've also come to realize over time is everybody, physicians know things on our side. We're educated, we learn things, we train through things, we're here to help you. But the only person who knows your body the best is you, because it's yours. So if something doesn't feel right, that's when you need to bring it to our attention. We can't help you if you don't tell us. All right, number 5, you want to trim your waist below 35 inches. Why? Because that falls into the bucket that we as physicians consider metabolic syndrome. So that's when we start to see that there's belly fat, the triglyceride numbers are high, your HDL or your good cholesterol is low, the blood pressure is high, your blood sugar is high. These are all the right ingredients for coronary disease, for underlying heart disease to develop. Those are all the ingredients that are usually mixed in there. Next slide. Number 6, and this has been reiterated to everybody already by more than myself, don't smoke. Smoking increases the risk of heart disease and stroke by 2 to 4 times. Women who smoke have a 25% higher risk of developing heart disease compared to men who smoke. Continuing to smoke throughout your life also shaves off 13 to 14 years of your life. And despite beliefs to the contrary, smoking just doesn't cause a risk for lung cancer. It causes a very important risk of heart disease. Next slide. How smoking damages your heart. Now, nicotine, we all know, is in cigarettes. It's also in the vaping cartridges. It makes your heart rate, it makes your blood pressure shoot through the roof. Carbon monoxide and tobacco that are in these products, they rob your brain, your heart, your arteries of oxygen. It damages your blood vessels and it makes your blood very sticky. When your blood gets very sticky, it is a recipe for clots. It lowers your tolerance for physical activity and it decreases your good cholesterol. And if you take oral contraceptives, it increases your blood pressure and risk for stroke and heart attack. Smoking and oral contraceptives together is a recipe for a clot. Those clots can be in your legs. Those clots can go to your lungs. I have seen them. Next slide. Question I get in the office, is vaping better than smoking? And then I get questions, is it better for me to smoke marijuana than it is for me to smoke cigarettes? My answer to everybody is, if it's something that you can inhale, my answer is going to be no. It is not smoking, vaping. There's no alternative, in my personal opinion, that is better. Just don't do it. There are ways to quit. There are resources to help you quit. And if you can tell your physician and you're ready to quit, tell us, we will help you, but it is going to be across the board. I can guarantee you, every doctor is going to tell you, you need to stop. Next slide. Next one, and we've talked about this as well, limit your alcohol intake. Moderate alcohol intake in women means 1 drink or less per day. Excessive alcohol intake can increase your blood pressure, increase your triglycerides, it increases your heart rate. For some people, it actually leads to heart failure. Different types of beer, wine, and liquor, they all contain different amounts of alcohol, but in general, a drink means 1 12-ounce beer, 5 ounces of wine, or 1.5 ounces of an 80 proof spirit, something like bourbon or vodka or gin. Next slide. This is not 1 serving of alcohol, okay? Just for reference. Next slide. This is important. Know your individual risk factors. The 2 things that you cannot change are your age and your genetics. No matter how hard we try, you can't change those 2 things. So I ask my patients a lot of questions, and I've had some patients look at me asking, like, why are you asking about my OBGYN history? You're a cardiologist. Why does that matter to you? But your family history is extremely important. And one of the things I do find with some of my younger patients is they are not as cued into their family history as I wish they were. So for anybody here, you have children, you have family, talk to them about what your own medical history is, because it matters to them. There are certain things that are genetic that if your children are aware of it, it is part of what they know is in their family history, and it does affect them as they get older, or maybe at this point in their life, but these things are important. Your OBGYN history is very important. I like to know how old you were when you, or even the next point on here, menopause and menarche, and whether or not you had any hormone therapy use. It's important to know when your menstrual cycle starts, where your hormonal period kind of starts to taper off, how many children you've had. Did you have a loss of pregnancy? Did you have a preterm delivery? Did you have preeclampsia, eclampsia, gestational diabetes? All of these things are very important because they do carry a risk from a cardiovascular standpoint later in life. Also, your cancer history is very important. What type of cancer you had, how it was treated, and I do like to get in touch with most of the patients' oncologists, especially if there's a concern that I have, whether somebody may have had radiation to the chest wall, whether or not they've had breast cancer, what type of chemotherapy did they get? All of these things are tied in because truthfully, and I think most of the panelists here will agree, your body doesn't work in isolated parts and it all works together. So when something happens in one part of your body, whether it was breast cancer, maybe you had chemo, you had radiation, or you had colon cancer and you had surgery, or you've had some other disease process and you've been treated for it, it does affect your whole body. It just doesn't stay in one part because that's where the problem was. It does affect your body as a whole. So it is important. So cancer history, we do like to know as well. Next slide. Number 9, don't ignore shortness of breath or swelling in your legs. I've had people who said, oh, well, I'm just getting short of breath, particularly the past year. Unfortunately, I've seen a lot of it. I'm just short of breath because I gained weight. I'm just short of breath because I've been not exercising. Those are things that can be true. Maybe you're deconditioned. Maybe you haven't been working out. Maybe you took a break from the gym. Maybe you're short of breath because maybe there was some weight gain, but that may not really be the answer. I have a lot of people who have said, well, I'm short of breath because I've gotten older and I just can't go up the stairs anymore. These are things that if you know your breathing has changed, if you feel that you have swelling in your legs that wasn't there before, these are important things because this can oftentimes be a heart failure. Then this is the way that it's manifesting. So 3 things that I put on here. So shortness of breath, particularly with lying down, is a very important and kind of clinical picture that we see with a lot of patients in heart failure. Swelling that you get in your ankles and your feet. Sometimes those things can be vascular, but they can be heart failure related. When you feel swelling in your belly, your appetite has changed. These are all very much heart failure symptoms that we do see. And weight gain over a very short period of time is another thing. If you can tell your physician, well, I've gained weight, but it's not because of the way I'm eating, something just feels off, you feel swollen, you feel bloated, it definitely can be heart failure that could be there. So don't ignore that. Next. Now, pregnancy and heart disease, yes, it does happen. High blood pressure in pregnancy. So we see it with gestational hypertension. We see it with preeclampsia. We see it with eclampsia. Those people who know that you've had a blood pressure issue in pregnancy, make sure your physicians know that when you follow up, even after delivery, even years after delivery, it is important. Elevated blood sugar or gestational diabetes during pregnancy, also very important for us to know. They are tied together, specifically gestational diabetes and any of the hypertension that we see in pregnancy. Those do end up being things that oftentimes we have to deal with later, or we start screening for coronary disease for these patients earlier. And we do start to see heart disease earlier than we would in the general population. Preterm birth does matter. So if you have had a preemie, that is something that is important to let your physician know. And if you've had a small for gestational age pregnancy as well. Next slide. This is one of the sources that I love to give patients to follow or to look for information, is something by the American College of Cardiology. It's a website called CardioSmart. They have a ton of great infographics that they use. So this is one of the things that I like to sometimes share with patients. And this is after pregnancy. I think a lot of us think that, you know, when you're pregnant, you're young, you're healthy, you know, certain things aren't going to affect you, but there are things that happen. So after delivery, if anybody here is either a new mom or if you have somebody in your family who's a new mom, particularly the things after pregnancy to look out for. If there's all of a sudden visual changes, headache, chest pain, palpitations, shortness of breath, swelling in the legs, these are things they need to be evaluated for. Don't sit and wait on that. These are things that can be emergencies. These are things you should call your OB for. They're things you can call your primary care for, but these are not things that you should wait and sit at home and just sit on. Causes of heart disease. Go back one, sorry. Causes of heart disease at delivery or soon afterwards. Like I mentioned, blood pressure is something, and I've seen it more and more often. I would say more in the past 5-6 years, I've definitely seen more of the preeclampsia, the gestational diabetes, and the eclampsia. And I think some of it is also because many women tend to have their pregnancies a little bit later than they may have in the past. And so, you know, when by I guess age cutoff, when you're over 35, you fall into a high risk category for pregnancy. The risk of preeclampsia, eclampsia, gestational diabetes, they are seen as you get older. These things are more common. So definitely I have seen more of this over the past couple of years. Okay, next slide. Cardiac conditions that affect pregnancy, heart rhythm issues, heart valve issues, congestive heart failure, congenital defects. But these are things that if you have these, usually your obstetrician has told you you need to see your cardiologist. And we deal with a lot of OBs hand in hand when we manage a lot of these patients. So this is not something that tends to go missed. If you have a pre-existing condition, usually your OB has kind of already cued in your cardiologist, or we've already gone through pre-pregnancy planning before you've gotten pregnant. So these are things that we can be aware of and stay on top of during your pregnancy. Next. Things you can do: keep your prenatal appointments, take your medications the way you're supposed to, get plenty of rest, monitor your weight gain. If your weight gain during pregnancy is more than it should be, your OB does weigh you every time you come in. So all of a sudden, if that weight gain jumps up more than what they're expecting, these should start to set off certain concerns. Manage your anxiety also, you know, even just to expect with labor and delivery, kind of find out what's going on in development with the baby. And don't forget to ask about yourself. What's your blood pressure when you go in? How are you feeling? And be in tune with your body. And during pregnancy, know what's off limits. No smoking, no alcohol, minimal caffeine, and obviously no drugs. Next. All right, so I lied. It's actually top 12, not top 10. Sorry. Next. All right, 2 important things. Sleep apnea, quality of sleep. The last year has been hard for everybody across the board. And I think anxiety has played and depression has played into a lot of lives, maybe in the way that it didn't. I think the stress really has hit everybody across the board. I can't say any of us are really immune to that. But sleep quality is something that I do find has been affected. And some of that can be stress related, but there also in the past year, many patients and many people in general have gained weight. And there is a form of sleep apnea that is related to your weight gain, is obstructive sleep apnea. So if you have either yourself or if you have somebody who's in the house and you're concerned that maybe they have sleep apnea, you're noticing they snore a lot, some of the signs to look for: loud snoring and sudden cessation or stopping breathing or gasping for air during sleep. is one of the things that definitely we do hear is probably the most common complaint when someone says, I think I need to be evaluated. My wife tells me like I'm snoring like this, or somebody will say that somebody in the house told them, I can hear you snoring from across the house and it sounds like you're not breathing. You wake up with a dry mouth. People who have frequent morning headaches, if you find that you're getting really sleepy throughout the day, not just I'm exhausted, I could use a nap, but you find yourself nodding off a lot, or you find that you're very just irritable, or you have trouble paying attention, you feel foggy during the day. These are very common signs of sleep apnea. And if you feel that these are any of these resonate to you, bring this up to your physician. There are ways to get tested for sleep apnea. Go for a sleep study. Sometimes it's not sleep apnea, but if it is important to have it treated. Sleep apnea is dangerous. It leads to hypertension. I see a lot of atrial fibrillation that's tied to sleep apnea. And there is a risk of sudden death. There's a lot of mortality that is associated with sleep apnea, especially when it goes untreated. So if anybody here feels like they fit any of those, or they're having any of these signs, bring it up to your physician. We can test for it. Next. All right, and stress, who doesn't have it, right? Everybody's got it. I think there isn't anybody here who can say they're completely stress-free. I think we've all got some component of it. Now, the combined effect from stress from work and social interactions, they all increase our risk of coronary disease. High stress life events were linked with an increased risk in developing heart disease, while social strain also increased that by 9%. This was from a recent study, actually. If these numbers are right, we could really, by managing our stress levels, we could find ways to really reduce our risk of heart disease. So stress management, the healthiest way, in my opinion, to kind of go about managing it. One, I think talking to somebody helps a lot. You know, finding that way to just woo-saw, I guess, is probably the best way to put it. Really just to talk to somebody, get those feelings out there. Don't feel like you have to keep them into yourself. Exercise is an excellent outlet for stress, whether it's a walk, whether it's a run, whether it's getting some just fresh air and being outside, changing your environment. There's been a lot of people who've been working from home, you know, not having that outlet, not having that social interaction, even at work, I think has changed things for people where your stress level is just different. So my piece of advice in regards to managing your stress, do it in a healthy way. You know, don't put it into having that extra cocktail at night or picking those foods that make you feel good. You know, with the foods that make you feel good usually aren't the ones that are good for you. I've joked around with patients that nobody ever says, I've had a really bad day, I just need some carrot sticks. I don't think anybody has ever said that. So, you know, find the healthy ways to, you know, to do something constructive. Try not to put it into the habits where it's smoking, where it's going to be drinking, where it's going to be, you know, eating our comfort foods. Find something that's going to help you in a way to just move past that in a constructive way to help your body and your mind. Next slide. And my last piece of advice that I can give that I think almost everybody here has also commented on, communication is unbelievably important. I think the physician-patient relationship is super, super important. I have to feel that my patients, when they walk out the door, feel that their questions have been answered. I have answered things that are so out of the realm of what I know and what I've been trained for, but you have to remember, we are people too. And whatever it is that's on your mind, if I can't find a way to help you, I'll help you, maybe point you in the direction that might be able to. But if you, and you know, this goes for so many things. If you have a concern about a medication, maybe I prescribed for you, don't just go home and say, well, I'm not taking this because it makes me feel terrible. Tell me why it makes you feel terrible. Let me help you figure out either there's an alternative. Maybe it's the dosing. Maybe it just doesn't agree with you. If there's a test that you're uncomfortable with or something you're scared about, tell me what your fears are and I'll help walk you through it. There's always a plan B, there's a plan C, there's always something we can figure out together. But communication is very important, both from doctor to patient and patient to doctor. If you have a question, ask before you go. If you have a question, call the office back if you have. I don't like for people to feel like they have extra concerns or question marks in their head and they feel like they didn't get a chance to ask me or they thought that I couldn't answer it for them. I'm here to help. That's what all of us are here for. And I tell most of my patients also, just write down if you have a question, bring it to us. We're happy to help. All right. Thank you guys. Have a wonderful evening. Thank you for your time.
Well, Dr. Chengat, thank you. And we do have questions.
Sure.
Good. Okay, so how can a person differentiate between anxiety/panic attack and a heart issue?
Okay, I get a lot of this. Panic attacks, I have not personally had one. I've had enough patients that have come to me with concerns that they have either they feel that it's a panic attack or they've been told it's a panic attack. Panic attacks are going to feel very similar to what a lot of us may envision a heart attack may feel like. Your chest is tight, your heart is racing, you feel cold, and you might be clammy, you might be sweaty. What my honest answer is, I will not ever tell you that it is anxiety unless I am really sure it's not your heart, because I have had patients where they may think it's anxiety or they may have been told that it's anxiety. And this happens a lot with women, to be honest. And by the time we've either done an ultrasound and we check the valves, we check your heart function, we've done a monitor. Sometimes it's hormone related. It could be your thyroid. It could be other things. So the way to sort that out is go to your physician and say, I'm not sure if this is my anxiety. I'm not sure if this is something else. And the only way to do that is there is some diagnostic testing to help pull that apart. So I don't want to tell you just based on symptoms that it's not, because there have been enough times people have come saying, I think it's a panic attack, and really it's actually not. There might be something there that we need to help you with.
Thank you. Also, is taking daily baby aspirin after COVID infection a good idea to prevent PE, stroke, and heart attack?
So that's an interesting question. Post-COVID, a lot of patients who were hospitalized were discharged from the hospital on blood thinners for some duration of time. For a couple of months, they were kept on full dose anticoagulation because of the clots that we had seen in the setting of having COVID. I do have a lot of patients who did stay on aspirin afterwards. I don't know if I would tell you that primary prevention to added post-COVID infection is indicated. We don't have guidelines on any of this stuff yet. Most of the patients that we see, well, I'll truthfully tell you, they are on aspirin because they have a different indication for it. They either have plaque, they have coronary disease, they have had a stroke, they have some other reason they need to be on it. So most of our patients are on it, or they've chosen not to come off of it. On that note, in the COVID period as well, we had a lot of patients who might have been on 2 blood thinners if they've had a stent, either Plavix and aspirin or Brilinta or Effient plus aspirin. And they had concerns of being on the blood thinner for that long. Usually after 6 months to a year, sometimes we take those patients off of both blood thinners and maybe drop it down to just an aspirin. In the year, especially last year, we really left people on both of those blood thinners together because the concern was, well, if they had COVID, are you at increased risk? Could something potentially happen? So we actually left patients on both of them. So in regards to, is it for prevention for having a clot post-COVID? I don't think I have a solid answer for that. I have to tell you, I think we're going to have to see where some of the information really leads us with that. But if you're able to tolerate it, and you don't have a bleeding predisposition, it is something reasonable to think about, but I would discuss it with your physician.
Okay, another one. If you feel bloated but lost weight, is that a heart concern?
If you feel bloated and you lost weight, that's probably a bigger question I think I can answer with a general yes or no. There are things that could be heart failure. If you're feeling bloated, you feel like your appetite may not be the same. If there's anything that goes along with it, that you're feeling out of breath, you're feeling that in particular, your endurance may not be what it used to, it is definitely something of concern to bring up to your doctor. And definitely something from a cardiology perspective, we can help sort out. Heart failure is something that we diagnose most routinely on a sonogram of your heart. There's 2 types of heart failure. So there's a type of heart failure where your heart doesn't squeeze well, and there's the type of heart failure where your heart squeezes well, but it's very stiff when it relaxes. So those type of things can be sorted out on a sonogram. So if you feel like that's a concern for who asked the question, that's definitely something to bring to your physician's attention. If you have a primary care, or bring it up to your cardiologist if you have one. We can sort that out for you.
Thank you. Okay, trivia time. Compared to men, women who smoke have a blank % higher chance of developing heart disease. 15, 25, 35, or 40? Nope.
Keep them coming.
Keep them coming.
So
Wow,
while we wait,
everything's
I just
40.
wanted to say thank you to all the panelists for your time and for your expertise. Some of the comments that we got in the chat was that this was very helpful, so we really appreciate your time. I also just wanted a friendly reminder that this webinar was recorded, so we're going to be sending you the link so you can either rewatch it if you have any questions or share it with your friends and family. You know, please pass it along. And in terms of prizes, you will be receiving an email from Liz just asking you for your address so that we can mail over your prizes to you. So again, thank you so much for participating. We hope to see you at another event in the future, hopefully in person next time.
And just to let you know, it's 25%. I'm going to be the winner.
Thanks again,
Thank
everyone.
you so
Have
much.
a great night.
Such a great night. Thank you.
Thank
Thanks
you.
for all joining. If anybody has any questions too about the physician, like to get in touch with them or anything, just email me. Everybody has my email. Okay. Thank you. Bye.